I know I went through that really quickly. Sorry, I just didn't have my other person over here, but we can open it to discussion and questions. I encourage you guys to provide me with questions and I'll answer them to the best of my ability. What do we got? I know I went through PTSD very quickly. Yes.
We have a question from Craig online.
Hi, Craig.
From a VR perspective, as far as PTSD, sometimes clients in a vocational setting will avoid triggers that commonly exist in general settings. As a rule, it is similar to anxiety exposure therapy to encourage them to confront and help them along and support them in those settings, or should we back off? Again, speaking settings or scenarios that exist commonly.
Interesting. Okay, so we're talking about trauma treatment here in some, correct? So should we challenge them to not avoid? In what settings? Can you summarize? Is it a voc rehab setting?
I think it looks like...
Craig, you want to clarify that for me?
Craig says
so,
yes.
Okay.
To your question.
Okay, thank you, Craig. You know, so from the perspective of trauma treatment, I think that do you want to clarify something, Walt?
We had another person say, can you summarize the question that Walt asked that's being asked now?
Yeah, I mean, hey, Craig, you want to summarize that question because it's very long.
Craig can take his microphone, I believe. Click on that bottom left and he can talk.
Bottom left.
On his, no, on
okay.
On his,
okay.
On his screen.
Craig, do you want to actually ask your question so I can hear you say it? No.
He should be able to speak.
So, you know, I'm looking at this question as, should we, okay.
Craig says he doesn't have a microphone on his computer.
Oh, Craig, jeez, okay, it's okay. So I'm looking at this question as, if they're in a work environment, should they be challenged? I think we need to make them function in the work environment and cope, so they need to be working with a therapist in order to develop skills on how to cope in that environment. So, they need to be fully ready to enter that work environment. If there are some triggers in that work environment, they need to process that in therapy, but they need to function in their job as much as possible. That's my thoughts. But I'm not a PTSD expert.
Craig said, so imagine a client who is robbed, doesn't want to work as a cashier.
Well, I probably wouldn't put them in that work experience until they process the trauma, and they may never want to be a cashier, and that's okay. As long as they're not avoiding exposure and discussing it in therapy. I mean, I think you can function without being in the same job environment.
Craig says, yes, exactly, but wants to work as a cashier.
Interesting. Okay. Well, there's some disconnect there. Thanks, Craig. Okay, so he wants to work as a cashier, but then he has triggers because he was robbed. So,
that's not fully acknowledging his deficit.
Yes, there's some impairments and disconnect there. And I might explore that with him. And I'm very direct in nature, and that's how I do therapy. So sometimes I rub people the wrong way. So I really challenge people, and Duke, sitting back here in the back, has seen me in action. So I usually call people on their stuff, and so that's how I'm not as sensitive. So I don't need to do trauma work in nature. But for TBI treatment, subtlety is not a benefit to have. So awareness of deficits. You're not going to get more awareness than me pointing it out to you. So, sorry, Craig. I work with TBI. Go. Yeah.
Craig says cash registers freak them out in certain situations.
Oh, Craig. Well, they need exposure, yes. Are they receiving therapy?
They need to call Liz.
They need to call Dr. Rizzo. Let me get her on the phone. They need, I mean, yeah, in order to benefit and start working in that job, they have to receive exposure to that. And that depends on how the therapist and they agree on how they're going to work on that. Oh, God.
Maybe they
Craig.
can get a job with no cash, just credit cards.
But you're still going to be in that environment. No, I mean, go ahead.
Craig says the client was referred for therapy, but is not following through.
Question, Craig, what do you think?
You shouldn't be doing job placement.
That's what I think, but I'm going to ask Craig.
Sorry.
Yeah.
Craig says, same as you, I'm direct.
Oh, awesome. Well, I think that's a good decision. I think there's times when you can't place someone in a job if they're not willing to do the groundwork. And there's a responsibility on their part. And we do not need to kind of support that. Natural consequences, big believer. My poor kids. Okay. Any more questions?
I have a question because when we were talking, and I'll try to sum it up so it's not too long when you're repeating it. How often do you see that someone is diagnosed, especially in the VA world, diagnosed with a concussion, but then later on, probably presenting something more severe and should be reassessed? Does that happen?
Okay, so maybe someone comes in with a concussion. We're talking about an acute setting.
Well, I'm talking specifically VA.
Mhm.
Someone was involved in an IED blast.
Okay.
Got out, and I have a specific person in mind.
Yeah.
Got out of the military. You know, the whole stigma of he was medic. You get back on. You finish out your tour.
Absolutely.
Oh, sorry, that works because my question's getting way longer than I wanted to. So, getting out, you go to Veterans Affairs to seek your post-deployment services or post-active duty services. You know, flagged for TBI because talked about the IED, but then, you know, when they went, I don't know specifically if they went to polytrauma or not, or I don't know if it was just the phone flag and then the PCP follow-up afterwards. You know, they assume concussion. But maybe significant other or whatnot, 5 years down the road, you're still seeing hearing loss, cognitive as far as memory. So part of you thinks maybe it was something more severe that was misdiagnosed. Does the VA open that back up typically?
They're always welcome to come back for polytrauma.
Okay.
If they're still having impairments, absolutely.
Okay.
We've seen people multiple times that are having continued impairments.
Yeah.
And maybe we take a closer look and see if anything else is going on. There's also oftentimes referral to neuropsych.
Okay.
As well, you know.
Okay.
So yeah.
Okay.
That person is
So it's definitely not something that is just like, well, no, 5 years ago you were just diagnosed with this.
I mean, we would never turn, you know.
Well, yeah.
But we also are going to delve into what other complications have you had over the last 5 years?
Okay.
What other treatments have you engaged in, or you know, are there any medical problem? I mean, there's a number of things.
Yeah.
That, how your brain is working, or your hearing. And in terms of hearing, like just in terms of veterans, they're just about everyone I encounter has
Some form of hearing loss from the, yeah.
So that ringing in the ear, because
Yeah.
they're trained with weapons, they're shooting guns, there's
Mhm.
glass, there's all that. There's going to be some damage.
Yeah.
So yeah.
Okay.
But yeah.
So it's definitely something that they can reach out either to their primary care or social worker to kind of reopen or reevaluate. Okay.
Primary care just needs to submit a consult.
Okay.
Who else wants to take a hit?
At Voc Rehab, sorry, another Voc Rehab comment. We don't see veterans as often, but I do tend to see a lot of domestic violence survivors that have had head traumas as well.
Right.
And it was never assessed at the time. You know, they're just now finally discussing that that's caused a problem.
Mm-hmm.
And of course, we make referrals and things like Do you no? Do you have anything to say about the whole domestic violence and traumatic brain injury correlation? I know that you're in the military more, but
I mean, in general, again, we look at the severity of TBI. You can ask the questions like, do you recall loss of consciousness? Do you recall any of that? You can have them further assessed in the civilian world and things like that. But again, you have that component with domestic violence. There's trauma. So are we looking at that in terms of those impairments? Are we controlling for that? You can go back and have CTs and things as well to see if there was any structural damage and take them through neurology. I mean, that's always an option as well. So did I answer that at all? Not really. Still
It
muddled.
was more of a comment. Like, do you have any experience in that too? 'Cause
You know, most of my brain injury experience, aside from the VA experience, is motor vehicle accidents. A lot of those. And then I think I had one stroke and one gunshot wound. So, yeah, so not a lot of domestic violence in terms of treatment, moderate to severe, that I've seen within our, in my world. So,
Thanks.
you're welcome. Oh, nice. What you got for me, Duke?
When it comes to establishing, the cognitive defect resulting from a TBI or anything like that, when you're looking at kind of getting an assessment or baseline assessment, at what point or what severity level would you suggest that a patient seek out, like getting a neuropsychological evaluation, trying to get an understanding of the defect resulting from the TBI? If it's moderate, lasting greater than 2 weeks, greater than a month, when would you want to look at something like that to see, of what level of loss there has been or the resulting damage?
One, are you talking about just the baseline?
Yeah, just baseline.
Okay, so you're not going to want to hit them during that PTA, so where they're confused and can't recall information, because it's going to get you nowhere. They're going to forget why they're there when they're in the room with you at times. So if you're looking at a severe, you want them awake and functioning and responding, so you're going to want them at least up there where they can follow commands and things, because they're going to be asked a lot. Medically, they need to not be complicated. So everything needs to be pretty stable to get that baseline. Same for moderate. For mild TBI, typically that they return to functioning within 3 to 4 months. If you're still having problems, I might recommend further assessment, maybe some screeners. One thing I use for patients, and just to do a screener, to kind of see what level they're at in terms of attention, focus, and I didn't bring a copy of it, but it's called the MOCA, MOCA, Montreal Cognitive Assessment. It's online, it's free, it's PDF. So you can administer it, and it has them basically sequencing lines going in order 1, 2, 3, 4, 5, 6, 7, 8. You have to draw a clock, time 10 past the 11, copy a cube. It has pictures of animals, so recognition there. It has a memory component. You present 5 words to them, and then 5 minutes later, while you do some distraction task, you ask for those words again. It has some comparison, some abstract thinking, how two things are alike, some language fluency. I'm going to give you a minute. You tell me as many words as you can that start with the letter B. They can't be names of cities. They can't be names of people. You time them. A minute later, you get that. Some working memory abilities on this screener, starting with 100, subtract 7, 93. Can you keep going? 86. Keep going, 79, right? So you do that during the distraction, but you also get a level of their ability there. So you have language fluency, you have abstract thinking. And then you go, okay, you remember those words I presented to you about a little bit ago? You remember me reading those to you and read them back to me? and they'll either go yes or no. Sometimes they have no clue, and that's fine. But sometimes I'm like, just take a second, take a breath, and try to think back. And sometimes they'll get a few. Now we do prompting, where we kind of give a category of the word. It's a type of flower, and then we give 3 different options of multiple choice. So you can give basic screeners over time, and then see if you want to advance to a neuropsych. So to kind of go back to my ramblings, but you can document progress and look at some function just through a screener if need be. That's all you have available. I mean, you know. So, did I answer that at all? Okay, I may not have answered that. I rambled. Nice. Walt.
We have a question from Jason.
Hi, Jason.
Can a child that received a skull fracture at the age of 18 months old remember what happened? Like who hit them? My grandson said he was hit, but did not know who. Is it possible for him to recall this from such an early age? He is now 7, and he states he was hit in the head. I am asking because my grandson was found with a skull fracture at 18 months old as a result from physical abuse and a CPS case. Both parents went to jail. I would like to know who did this. Will he have PTSD from this? Would this have caused mild to moderate damage?
Oh gosh.
I have not seen any behaviors thus far. I was just wondering if this can cause PTSD later in life.
I mean, okay, you should have already seen that PTSD. If they're 7 at this point, you would likely still see it. Can he have a memory of being hit? Yes. Is that memory likely skewed? You know, in terms of children at 18 months, not highly reliable data. Can he have the memory? Yes. If you've put in all those protective factors, supportive environment, done the things you needed to support that child, those are some protective factors. So I think that's all I can offer on that. So I hope that answers that, Jason. Oh, okay.
This is from Stephen.
Hi, Stephen.
I love the MOCA and find it to be helpful screener. If you do use it multiple times, are there alternative forms to reduce practice effects? Also, has the test been adapted to other languages besides English and Spanish?
Don't know that it has, and there are alternate forms to that. I think there's 2 or 3 other forms of it. There's the original, and I think there's a B and a C. Don't quote me on that. I'm not 100% accurate on that, but there are alternate forms, and I have those. And I can send them out if that would be of use, if that's possible. If I sent them to you, Walt, and then...
I can do that.
Okay. I made it a prompt on Monday to recall that.
Stephen says thank you.
You're welcome, Stephen. Any other questions? This is fun.
Can you talk more about what you do?
Mm-hmm. Yeah.
The polytrauma. You're part of the polytrauma.
I am. I'm the only psychologist within the polytrauma clinic, within the VA system. There's a lot of pressure on my plate there, being the only one. So what typically happens when we get a referral to the polytrauma clinic is I get, the person comes in, they see our resident and our chief, which is our rehab doctor. And from that examination, they send out consults to speech, physical therapy, OT, audiology, optometry, and me. So we all kind of take a look because, again, it's a multidisciplinary approach. Once we all see them, make recommendations, whether we're going to further treat or not, or send them elsewhere, we meet as a team and staff that case. We talk about them on why we think deficits are occurring and what would be best. Now for me, being in the polytrauma clinic and knowing that veterans have to tell their story a million times, so once they come in and they've told their story a million times already, and I haven't made them tell that story again, because I am a psychologist and I like to hear you tell your story. We just love that. I understand that, so if it's something I can treat in a short amount of time, I'm not going to refer them out. I mean, I am a psychologist. I am trained to do work that's not just TBI. So that's assuming they're not within our service of moderate to severe TBI. If it's a specialty case, again, if it's PTSD, I do refer them out if they're ready and willing, if that's what they want. I talk to them about options. And I say, you know, you can come talk to me, and we can kind of help you develop some coping and things like that. I said, but this is what you need, and it's up to you on what you want to do. But keep in mind, yes, you will have to tell your story again, but that's part of it. If they do have a moderate to severe injury, they become ours. If they're service connected for a traumatic brain injury, they are ours. And it depends on what they need. Do they need to, is it a chronic grief issue? Is it an adjustment issue? And kind of diving into those topics and not being afraid to talk about things. Is it that I don't know how to meet people, or I don't know how to socialize, or I'm embarrassed because I walk differently, or my gait is abnormal? I have a walker now, and that's not cool at 35. Okay, well, let's talk about that. And then, you know, when families bring home an individual with a severe TBI, that's a whole new dynamic, right? So they're not prepared. I don't know about you, but nobody in my family was telling me about TBI growing up. You know, that's not what I learned about. So you have the individual. You see them, they look like your parent or your loved one, but they're acting totally different. What's this about? You also have this sometimes where the individual gets overstimulated. So here's all this chaos going on in the home. There's kids running around. What's the caregiver going to do? So I work with the family. That's a big piece of what I do, providing education, ideas, but also in other areas, like with speech, they're talking about structuring the environment to where organization and sequencing can improve, or compensatory strategies on those things. So I work with the team too, but a lot of it goes into family education. Like I said, the patient that is highly impulsive and says inappropriate things to people randomly walking in our clinic, I pretty much say sometimes there's inside thoughts, and maybe that should have been one. And, you know, I wait till rapport is established before I delve in that hard. But this patient in particular responds really well to that. So what else? I'm trying to think. I think that's all. I'm sure I do a lot more. You know, finding resources. You know, we have a social worker who is our coordinator in polytrauma, and we work together to find resources. What do you know about? You know, you've been in the VA system longer than I have. What do you know about? Here's what I know from working out in the brain injury world outside of the VA, and this is what's out there. This is my experience in working. You know, I did assessment for voc rehab for a while, so here's my knowledge on that. So just kind of brainstorming. One thing with brain injury, you have to think outside the box all the time. There's no one way that works for everyone, so you have to take those strategies and adapt them. I was trained in children and family in particular, so this world works really well for me. One of the things when I look at a moderate to severe TBI, I look at them from a developmental perspective. So where are they in terms of development, on their coping strategies, on where their level of understanding socially. You know, I may have a 33-year-old individual presenting as a teenager, and they're making decisions that a teenager would make, and their mom's going through it again. So I have to support mom, and then I'm like working with him on getting him through this. time in his life and adjusting to that and being okay that his mom's going to be there to help him, you know? So anyway, I think I rambled. Go ahead.
Since you come from a non-VA world, let me ask you this.
Yeah.
Do you ever have, or have you had any experience like with athletes coming in with repeated concussions, things like that?
I was waiting on CTE to come up, right? That's where you're going, right? I think I've had one person come in with a concern of CTE. You know, I can't delve into CTE. I'm not going to delve into that today. And I'll say that not because it's not a huge topic. It's a very relevant topic and it's of concern, especially for our veteran population with repeated blast exposures, you know, and studies are starting to come out. And I think advances in technology and things as we're trying to identify it before the person dies. I mean, that's the goal, right? And how to intervene. Because right now we don't have enough knowledge. And so that's the reason I can't really talk about it because there's not enough out there.
Right. There could be some kind of technology
Exactly.
that can do the brain screenings.
Yeah,
for
and
other things like MRIs and things.
yeah, a couple colleagues and I were talking about this presentation today, and we were talking about CTE, and I'm like, I know it's going to be a hot topic, it's going to come up, so I've been waiting on it. But I didn't get a look at any research, but she mentioned to me that there's someone within military area that's doing some research on catching this beforehand, and I hope so, and I need to
Think
read
about
some
a kid
research.
Comes out of high school,
right,
played sports all the way through.
I know.
And joins the military.
exactly,
Goes right into that environment.
You've got multiple
risk factor there.
exactly multiple risk factors. My kids won't be playing football. I know that. I'm going to wrap them in bubble wrap, put them on their bicycle with their helmet and snowsuit. Sorry. But yeah, I mean, it's a concern. Do you have another question, Walt? I feel like someone's out there thinking, am I going to ask this? Oh, cool. Go ahead.
Do you know any like generic resources for PTSD and then also TBI? I have very limited knowledge, maybe online resources. Or...
I think a good place to start is for Kentucky in general, just for brain injury, is the Brain Injury Alliance of Kentucky. They'll have links to all kinds of resources. It's going to be a great source. You know, in terms of PTSD, that's great. The VA website has a lot of resources as well, with TBI as well. I shouldn't say I went straight to BIAC, but the VA has a lot of, like, once you go into the VA and you look at the PTSD information, the TBI information, it's going to connect you to other resources throughout. So that's a good option too. So I would start there, and then I'd probably just grow out of control, because there's tons of research just on brain injury, and there's tons of research on PTSD. So, yeah.
We don't have more questions online.
All right. No more questions. No more in the crowd.
What was your training? You said you had a children's
Yeah.
family.
So I was trained, let me just, I'll start. I got a master's degree in clinical psychology at Eastern Kentucky University. And then I got that degree and I thought, what I'm going to do? And I decided, I'm going to go to school more. And so I went to Spalding University in Louisville. And my idea, because EKU has a developmental disabilities clinic, I was like, I'm going to work with children. I love it, you know, and children with developmental disabilities. Love that, right? So I go to Spalding, specialize in children and families, still loving it, and that's the plan. I go on internship, and my internship was in rural Eastern Kentucky in Hazard, in a psychiatric setting and a comp care setting. Really enjoyed that. I got to do a couple of different things. And then I got my first job. My first job I chose based on it being close to my home. And it happened to be in a brain injury setting. And I thought, oh my goodness, how am I going to do this? I don't have the experience. I did work with a neuropsychologist for a while doing testing for voc rehab for a while. So I did have some supervision. So I sought some guidance from a supervisor, and she said, so funny, because she was a children and family person. She goes, I'm going to work at Stepping Stones. It's not Stepping Stones anymore, in Louisville. And it works perfectly. And she said it'll translate. You'll take the same stuff you're doing with kiddos and families and just adjust that to meet the needs. And that's what it did. And my supervisor, my postdoc year, the first year, was a neuropsychologist. So that helped too. And so I just fell in love with it over time, and I stayed with it. And then I spent 6 years, I think, running a brain injury program here in Lexington. And my family grew, so I didn't have time to devote to that program, and I didn't want to do it a disservice. So an opportunity arose at the VA to work in brain injury and do what I love, and I jumped on it and interviewed and got the job, thankfully. So, but yeah, sorry, that was a long story. In sum, I fell in love with it. So.
In TBI clinic, are you doing more like rehab type stuff, or do you do any kind of like therapy? You mentioned like some smaller things you do. So are they more therapy related or more rehab related?
Depends on the client and what they need. Yeah. So that's only 50% of my world at the VA, by the way. So I also have a psych testing gig. I test for ADHD and do transplant evals. So talk about those too. Yeah. Anything else? Am I off the hot seat? All right.
We don't have any other.
I think so. Well, I appreciate all the questions and the attention that you gave me. I can see those in the room. Hopefully those online attended as well, but I do appreciate the questions, well thought out. And, you know, if there's any more questions, I don't know if Walt can direct you to me. That would be great. Okay. All right. Enjoy your weekend. Thanks. If you guys just want to talk to me outside of the presentation, that's fine too. Sometimes I'm